We're live here, which is good. I just got to do my So the I'm just going to do. I had to do it before 7:10. So in some ways, you could argue I have gone a little bit too soon on this because I haven't done my Instagram thing. So I'm going to do my Instagram thing. Good evening, Instagram. So they're not live, the Instagram people. So because I can't go live on Instagram, so it's another day. It's another non-live Instagram feed. I'm on the Facebook. I'm on the YouTube. I haven't checked my TikTok. When I get 1,000 subscribers or whatever, I will be on TikTok, I think. I'll give it a go anyway. But I'm not on Instagram Live. So if you want live questions answered, come to Facebook or YouTube. We're talking about acne, scars, and moles, and inverted nipples, and tear troughs, and stuff like that. Fascinating stuff. Can't say much more about it because I'm about to do it on the Q&A. So yeah, sorry, Instagram, I'm still not able to be live with you, but maybe one day we'll get that feature back up and running when the powers that be see the light. Okay, so let's see you over there at the Staiano clinic. It is. So yeah, good evening, everyone. Sorry to keep you all waiting there for that Instagram thing. Kind of still a bit on holiday thing, so I had to sort of rush in and do this. I know I am working this week, so by rights it should be sort of okay to say that I'm doing this, and I did say that I did agree to do it, so I'm doing it. I hope if anyone is on holiday, hope you're having a good time on holiday. But yeah, I'm in work tomorrow, so it's kind of like a work week. So yeah, if you've got any questions, please do ask me directly. If you haven't got any questions, then let's see what other people have said. I had a mole removed and it needs to be done again. Does this mean it was done wrong first time? Well, not necessarily. The question is why you're having it removed the second time, I guess. So if you're having it removed because they've left a bit, and usually I guess that would be a shave excision where you haven't got it all down. I always warn people with the shave excision, if there's still a bump there, you might have to have it done again, and potentially with a shave there might be a dent there, and you might have to have that excised. So you might need a revision. That would be classed as a revision. And does that mean they've done it wrong first time? I mean, you could call it that. I mean, it's a bit harsh to say done it wrong, but whenever we do surgery, we are always trying to make things perfect. But I think most / all plastic surgeons, and maybe all surgeons, but certainly all plastic surgeons, will factor in an element of potentially having to do revisions, call it what you will, touch-ups, and potential procedures to make things perfect if they're not perfect first time. So if you want to say that's done wrong, I think that's harsh. I don't think it was done wrong, but there's often an element of that. However, with mole removal, there are situations where it might not be that there was a problem. It might be that so if you are happy with the scar, if the scar looks fine and you're being told you need to have it done again, there might be an issue regarding what the mole was. So if it was a skin cancer, and if it wasn't completely removed when they look at it under a microscope, so what we do is we take a margin often of skin, of normal skin. We often aim to obviously get the whole of the thing out, whether it be a or whatever it is, if it's mole or a skin cancer. Often we don't, you're not 100% sure that it is a skin cancer preoperatively. So we always aim to get the whole of the lesion out. But sometimes when when you have it removed and you have the scar, you might look like there's nothing there. But sometimes when they look at it under a microscope, they say if it comes back as a skin cancer and it's not all out, if it's coming up to the edges of the specimen, if there's not a clear rim of normal skin, then you might need a further excision. So I wouldn't say that's necessarily it's done wrong. That would just be a consequence of it being a skin cancer, especially if they, you weren't sure whether it was a skin cancer beforehand or not. The other type is a melanoma, which is a specific type of skin cancer, which is a little bit different to other types of skin cancer, mainly because it has the virtue of being able to spread to other parts of the body. And for that reason, we often want quite a large margin around a melanoma. So even if you think it's a melanoma, when you go to remove the mole, most of us would have just remove it with a little bit of a margin, just a few millimeter margin, and then we'd see the aspects of that melanoma. Particularly, the thing we're looking for is how thick it is, how deep it is, because the depth will dictate the margin of excision that we require. So it will be usually a 1 or 2 centimeter margin around the melanoma that's required. And usually, rather than just taking a 1 centimeter margin for the first bit of melanoma, we don't do that. We just take a little margin and then we do a 1 or 2 centimeter margin around the scar. Because a 1 centimeter or a 2 centimeter margin is quite a significant margin, and that's a peripheral and deep. So it's quite a large piece of tissue that's removed. So you usually want to be sure, first of all, of the diagnosis, and you want to be sure whether it's a 1 or 2 centimeter margin. So you will kind of routinely require 2 operations. If it's a melanoma, it's kind of standard. So that's definitely not gone wrong if they say, it's a melanoma and you need to come back for a second excision. That doesn't necessarily mean the first one was done wrong. It just means the first one was just getting the lesion out and assessing the depth of it so that they can plan the second operation. So if we know it's a melanoma, we will often discuss this with you prior to the first one to say, look, we're going to just take it off with a minimal margin or a few millimeters, 5 millimeter margin, say, and then we're going to, if it does come back as a melanoma, based on the depth, you'll need another operation. So it's always good to have these conversations before the operation so you don't get a shock and say, what, I need another operation. And that's kind of standard. But, not particularly, that's always standard, but especially if it's in like a cosmetically sensitive area, you don't want to be taking 1 or 2 centimeter margins until you know, first of all, you have to take a good margin, and secondly, the extent of that margin. So, yeah. So it doesn't necessarily mean it was done wrong. There are circumstances where you will potentially need another procedure if you have your mole removed. Some will be for cosmetic reasons, as I say, if it's a bump or a dent, particularly after a shave excision. But if it's a formal excision, they will usually be due to the histological results once we sent it away as to what it was and how much of a clear margin there is. If it's not a melanoma, if it's just like a BCC or an SCC or what we call a non-melanoma skin cancer, you usually just need a clear margin. So we usually cut those out with a sort of 3 or 4 millimeter margin and hope just to get a clear margin. And as long as the margins are clear, usually that's acceptable. But they would normally be discussed at a multidisciplinary team meeting to ensure they're comfortable with the margins and the aspects of the tumor. But this is something to be discussed. So yeah, so it's not unusual to need a second operation, and it doesn't always mean that something's been done wrong for the first one. In short, can CO2 improve a scar? Oh, how do I say this? I would say that there's a lot we don't know. There's a lot we don't know, and I know that. I know that I don't know a lot of stuff. So I know enough that I can't say this does definitely, particularly definitely not work or work. I mean, and I know that people do things like that. And I've seen them do these, like inject CO2 into scars and stretch marks and things, and they propose that it does improve them. I'm not convinced, is all I'm going to say. I'm not convinced about it. I don't do it and I don't offer it. So you could say I'm biased. Or I suppose someone who does it is biased. I don't know. All I'd say is, look, do your research on that. But I'm not convinced of that. But someone somewhere has obviously thought it's a good idea and is doing it. and someone has actually come to this and asked the question. So obviously it's sort of out there enough that this question has been asked. But as I say, I'm not convinced about it myself. All I would say is do your research. If you can find someone with good before and after photos, when you're looking at scar improvements, you want a mature scar. So ideally, really a year old. If you have a scar kind of less than a year old, if you have a scar at 3, 4, 5, 6 months, and then they say, oh, we've injected all this CO2 into it, and look at it at 12 months, it's so much better. I'd be like, well, it would have probably got better anyway at 12 months, unless they've injected half the scar with CO2 and there's some kind of trial like that. Then that might be, valid. If they've said, look, this half's been injected with CO2, this half hasn't, and look at the one that hasn't is a lot worse than the one that has, then that would be convincing. But yeah, I would say do your research on it. But I'm not sure whether it does or not. But I do know that some people think it does, and so that's the beauty of this world. We've all got life experience, and we've all got our views about things, and you just got to take advice or take stuff away and make your own decision. Not very helpful, is it, on a medical thing like this? But anyway, that's where I am on it. I'm not convinced myself. Can we correct congenital ear deformity for a child? Short answer, no. I'm not going to say probably. No. 2 reasons. First of all, we don't do children, so that's kind of nip that one in the bud. You have to be over 18 to come to the clinic, because the CQC approval or what have you for the clinic. We haven't got approval for under 18s. It was quite a lot of extra work to get CQC accreditation to treat children, and the sort of work that I do is there's not large numbers of children. There would be some moles, there would be some prominent ears and things, but not enough to warrant the amount of work that we required to get CQC registration for children. So I decided not to go down that path. So that's that. But the second part is that congenital ear deformities are usually quite complex. Usually significantly. I mean, you could say a prominent ear is a congenital ear deformity, but they're usually more complex than a standard prominent ear. A prominent ear usually has pretty kind of standard aspects to it, either a lack of an antihelical fold, which is this fold here, so a lack of that, or a deep conical bowl, which is sort of bowl bit of your ear, or a combination of the two. And so there are sort of procedures to correct a prominent ear. Congenital ear deformities will often have much more nuance, a much more requirement for reshaping of the cartilage, and would normally be done by an ear specialist. There are a few in the UK, and that's the sort of work they do. That's their specialty. Mark Lloyd used to work at the clinic and was an ear specialist, and they're dotted around the UK. There's not a huge number of them, but you want to look for David Galt was always the main name. I'm not even sure if he's still working. He may still be working, but yeah, there's a few names in ear deformity, and you'd probably be wanting to be treated in a sort of dedicated unit where there are specialists for that. So wouldn't be our clinic, no. Do we offer tear trough fillers? No, we don't. So the tear trough is this bit here where your tears will trough. And you can put fillers in those areas to facial rejuvenation. Nothing specific about tear trough. We don't offer fillers. We don't offer Botox and fillers. And I know what you're going to say. I know you're going to say it's obvious we should do it, and it's a big market and all those things, and we have done it in the past, and we have been in and out of it. I've never done it personally. I've never really, and I think that's probably the problem, really, because I've sort of produced most of the content for the website and the promotion, the emails we send to people and the information and things. So that's kind of been driven by me. And because I don't do Botox fillers, I haven't really promoted it. as I say, we have had people who do it, and the surgeons of the clinic do it, but I don't really promote it at the clinic because I'm really promoting. It's really what most of the stuff we're doing is minor surgery, moles, lumps, bumps, cysts, local anaesthetic procedures, and we're not doing any Botox fillers. So no, we don't offer tear trough. If an inverted, I read on your website that in some cases after surgery for inverted nipple correction, the nipple can go back and the surgery will need to be repeated. In this case, would the second surgery be free or will I have to pay for another surgery? It'll be free. So if it goes back within a reasonable period of time, and I'm sure we've got a time scale on it, I think it's 6 or 12 months, I'm not sure. But within a reasonable period of time, as long as it's not sort of a second pathology, you have other children, and you breastfeed and things, because these things can cause fibrosis of the glands, of the ducts. And we said that if you've had an inverted nipple correction, you probably wouldn't be able to breastfeed, so that would probably be a moot argument. Yeah, absolutely. I mean, I think one of the things about the clinic, and one of the things that I always say to people who say, you know, perhaps there's cheaper places to have procedures, we do focus heavily on the aftercare. And if it's not right, whether that means your inverted nipple inverts or your mole still got a bump there or a dent or things aren't quite right, we will not charge you to fix it. We will fix it free of charge. And it is something to kind of be aware of with an inverted nipple correction, because it is not an unusual complication. It's not a usual complication. I mean, we always plan to get it so that it's a permanent solution. But one of the risks of inverted nipple correction is that it can invert again. It can pull in again. And by all means, we will do it again. The problem with these things is you're often dealing with scar, and there can be the law of diminishing returns if it goes in and in. And I have had patients where it's gone in again. Yep, do it, no problem, fine. It goes in again. Do I do it again? Do I do it a second time revision? Probably did. And then it goes in again. And every time you're doing surgery, you're getting more scar. So I always say to people, look, we will do everything we can to give you the best result possible. Sometimes the best result possible may not be as good as you would want. You know, it may not be 100% fully out. There might be that bit of tethering still there. And we, you know, I'm not saying everybody, but sometimes you get in these situations where you're fighting that scar tissue. And every time we do surgery, every time we do anything to anyone, we're causing scar. So, you know, you're fighting scar with scar. So it's very hard when you're desperate to have a happy patient. But, you know, sometimes when there's just a lot of scar tissue beneath that nipple, it just keeps on scarring and pulling down. You know, it's like there's not that much you can do. Sometimes it's just a risk with inverted nipple, but certainly we will do everything we can to make it come out again. And if we feel that doing another revision, doing another pull out, you know, eversion procedure is right for you, we would not charge you for that, and as long as it's not like 5 years later or something. Yeah, as I say, it's one of the things that I try and kind of build the clinic on, the looking after you, and, you know, no hassle, no quibble with revisions and stuff. Look, there's a problem, we'll just get it right. And I'd rather sort of maybe charge a little bit extra at the front end to really look after people once they come through. And yes, we probably do lose people who will go elsewhere, and I understand that. But, you know, we're all about giving a really good service to the people that we do treat. That's kind of what we're after, what we're about. Do you do removal for nodular acne? Well, one of the thing about sort of treating acne and things, I mean, the treatment of acne is with a dermatologist, and we're all plastic surgeons, so we wouldn't treat acne. So we would not treat your acne. So if you've got active nodular or any type of acne, then you would need to have that acne treated by a dermatologist, and that would probably more be like either systemic, like tablets treatment, or creams, or, you know, general treatment to try and dampen down that inflammation and to try and improve the acne, and that would be the first thing to do and the right thing to do, rather than treating one specific area of the acne. So we do get into treating things once the acne has all been treated and all sorted and all fine, but you might not need anything. That's the whole point of when acne is all sorted and fine. Sometimes you get like pits, you get little, call them ice pick scars, little sort of dents and picks where the acne has been, and we can certainly do things to try and help those things. But the mainstay of acne treatment is medical, is not surgical. So although you might feel if you've got nodular acne, you've got lumps, you know, we say, oh yeah, we'll remove your lumps and bumps. You feel that you've got lumps. It kind of would be wrong of us to start cutting those lumps out, because it's the underlying acne that needs to be treated, not that specific lump or those specific lumps. The underlying acne needs to be treated. And once the underlying acne is treated, often that's it, the lumps go and you're better. If you have any sequelae once the active acne has been treated and you've finished your treatments and you're all sorted from that perspective, by all means we will get involved. But the majority of people don't need us, to be honest with you. You probably think you do if you're in the active stage, but once it's all settled, you usually don't need anything, or at least it's pretty marginal what we can do to improve things. So if you've got active acne, then really it's a dermatologist or your GP you need to see to look at treatments for that, rather than worrying about one or two specific areas that might be causing you concern, because you wouldn't really want a surgeon going in and trying to treat those areas in the presence of active acne. So it's a medical treatment that you would require, which would be your GP or a dermatologist. So not for us. And these sorts of questions, these sorts of things, you know, when you've got areas or issues, this is why we often say to people, look, do this, you know, put in a question first, send us a photo, really helpful, send us a photo. We're getting a lot on WhatsApp, you can email it, whatever, send us so we can give you these opinions, these ideas, rather than you having to come to clinic and then kind of get told this, and then you come having to think you get yourself sorted out, and then we kind of say that we can't help you. So this is really helpful to ask these questions, and we kind of encourage it to ask the questions before coming to clinic, because it helps you to get an idea of whether we can help you at the clinic. We don't want to waste your time, but it also helps us because we are doing these see and treat appointments now, where we're booking out big lengths of time within the clinic to actually see you and treat you. So if you're not appropriate for treatment on the day, it kind of helps us if we can talk to you before coming to clinic, say, look, you're not really suitable, and that's why the photos are really good. Look, you're not really suitable, you need to see a dermatologist, you need to see a GP, get things sorted out. Once it's sorted out, come back and talk to us. So that kind of helps us as well, because then we don't book out 2 or 3 hours in the diary to tell you that, and then so it's a win-win really. So that's kind of how I want the see and treat to work, to kind of, it's not quite giving you a consultation, but kind of giving you an idea what can be done for you and whether it's right for you and how much it's going to cost, importantly, before you even come to the clinic, so you can make a judgment of whether it's worth your time actually coming to clinic. And when you do come to clinic, you know, potentially we can do this surgery on the same day as the treatment. What's this? We've got some weirdo on the hand pink wavy. Yeah. I mean, you're always going to get one, aren't you? There's always one. We can't. You can do your best to block these people, but they're going to get through whatever happens. Hand pink wave. I don't even know. I don't even. Don't speak Japanese, so I'm not quite sure what that is. But anyway, we're a professional here, professional outfit, so we're going to rise above that. We're going to ignore that. And yeah, well, anyway, thanks for the comment, Simon Fiarby. Very kind of you to leave a comment, because that is the lifeblood of the outfit. So it is nice, always nice to have a comment, even if it is marginal in terms of helpfulness. But the first step is to get the comments, second step to get helpful comments. So I mean, we're halfway there with that one. So if anyone else wants to do a helpful one, now's the time. But I understand that you're all busy, and you're all busy people. You've got homes to go to and things to do. So if that's all, if it's just Simon for your advice comment, then I think we'll call it a night. And I mean, is this the hand pink waving? Is this what he's on about? Am I doing a lot of that? Maybe I am. Maybe I'll roll back the VT and have a look. Anyway, yeah. So have a good evening, and I'm actually on holiday next week. Full disclosure, I haven't booked anything, and arguably I am discovering that I have left it a little bit too late. So you could argue, there would be an argument to say I should have booked something before now. I think that'd be quite a strong argument, but anyway, we are where we are. So I haven't actually booked anything, but I probably won't be doing this. I will probably find a last minute Marbella all inclusive. So I'll be on the Sun Lounger, but week after, crumbs, that's looking into the future somewhat, but week after, quite possibly I will be here. If you've got any questions, you know what to do. Yeah, don't need to say it by now. Yeah, leave a comment, call me, WhatsApp me, usual whatever, you know, sort of ways of contacting, and I'll do my level best to answer it. So yeah, see you in probably 2 weeks. Have a good evening.